Welcome, everyone. Thank you for joining. My name is Jay Cranston, and I'm the marketing manager at Signifier Medical Technologies. And joining me today, I have Dr. Sharon Morong. Hi, Dr. Morong.
Hi, how are you?
Good. Thank you for joining us, and thank you, everyone, for jumping on. We're excited. We've got a great webinar planned for you. And before we get started, though, I do want to mention the Q&A segment. So we will leave 10 to 15 minutes at the end of this webinar to answer any questions you may have, but feel free to ask questions in the Q&A section at the bottom, and we might answer some of those directly in the chat, or we'll leave them for the end for Dr. Morong to answer. And just so you all know, there will be a recorded version of this webinar available within a couple of days on YouTube, and eventually it will also be on our website. So keep a lookout for that. So for today's webinar, Dr. Morong will be discussing daytime neuromuscular electrical stimulation therapy for snoring and mild sleep apnea, a non-surgical option for the otolaryngologist. So patients with primary snoring or sleep apnea are often referred to otolaryngologists when PAP therapy or oral appliance therapy is not successful or well tolerated. So the current treatment options and the role for a novel non-surgical option for these patients will be discussed. And I want to thank Dr. Morong for presenting her webinar this evening. Dr. Morong is an otolaryngology head and neck surgeon certified by the Royal College of Physicians and Surgeons of Canada, subspecializing in sleep medicine and sleep diagnostics. She's a lecturer in the Department of Otolaryngology Head and Neck Surgery at the University of Toronto. And during her career, she's received numerous awards, published multiple peer-reviewed articles and book chapters on sleep medicine and sleep surgery, and has spoken on national and international platforms about drug-induced sleep endoscopy. She's now the director of the Sleep Endoscopy Centre for Snoring and Sleep Apnea, with a special focus on CPAP alternative treatment options for patients with sleep apnea, which is what she's going to be talking about today. So without further ado, thank you again. And here we have Dr. Sharon Morong.
Okay, great. Good evening, everyone. And firstly, thanks to you, Jay, and your team for inviting me to come to speak today. These are my disclosures. Now, I'm an otolaryngologist that practices sleep medicine and sleep diagnostics here in the Greater Toronto area. So the majority of my practice comprises assessing patients for a variety of sleep disorders, testing patients where appropriate, and diagnosing with overnight polysomnography or home sleep apnea testing. And because I am an otolaryngologist, I get a lot of referrals for patients who snore or who have sleep apnea that are either not tolerant to or they're not preferable to the option of PAP therapy or oral appliance therapy. So they're coming to me to look for alternative options. Now, for these patients that are looking for alternative options, I give them the option of having drug-induced sleep endoscopy done. And with drug-induced sleep endoscopy, what I'm able to do is identify the sites or the anatomic sites of snoring and sleep apnea in these patients. And with that information, I'm able to kind of have a more comprehensive discussion with the patients about what the treatment options are for them and what may be most suitable. So what is snoring and sleep apnea? When a patient is sleeping, the upper airway sounds or vibrations that can be heard at night is snoring. When a patient's airflow is reduced or it stops for 10 seconds despite the patient's continued effort to breathe, that is obstructive sleep apnea. There was a literature analysis that was done by Dr. Malhotra et al. That looked at the estimated global prevalence of obstructive sleep apnea. And for obstructive sleep apnea, they defined it as an apnea-hypopnea index greater than 5. And what they found was that in adults aged 30 to 69, the prevalence was close to 1 billion individuals. And the majority of these individuals had mild sleep apnea. It was also estimated or expected that this prevalence would increase with age and BMI over time. So when we think about obstructive sleep apnea, there is a spectrum. On one end of the spectrum, we have primary snoring or mild sleep apnea. The other end of the spectrum, we have patients with severe sleep apnea. So these are patients who have obstructive events at least 30 times per hour. And I think it's important to discern these differences in severity because it often changes the conversation we have when it comes to treatment goals. So for example, when speaking with a patient with severe sleep apnea, the conversation is often centered around treatment to mitigate cardiovascular risk and improving quality of life. However, when speaking to a patient with primary snoring or mild sleep apnea, conversation tends to get centered around improving quality of life. And that can be snoring, that's causing marital discord, broken relationships, non-restful sleep for the patient, their bed partner, daytime fatigue, the inability to focus, to perform fully to their full potential during the day, mood instability, depression. So many different symptoms that a patient may present with, but all equally valid reasons to treat. So when we look at this spectrum, which or who are the patients that would typically present to the otolaryngologist? There was a prospective study that was done at a sleep center in Chile, and this prospective study took place over a course of 3 years. And they looked to determine what is the sleep apnea severity profile of patients being referred to their center from different medical specialties. And what they found was that the majority of patients who were referred from otolaryngologists for sleep studies actually ended up having mild sleep apnea. Now, this is one study and one location. Much more research will be needed to further explore these findings, but I think it's important to acknowledge these findings because from my experience as an otolaryngologist, when I get a patient or I get a referral for a patient with snoring or sleep apnea for surgical assessment or to discuss surgical options, it becomes quite clear after having a discussion with that patient, particularly patients with mild sleep apnea, that they've come to me because the option of wearing any device at night, be it PAP therapy, oral appliance therapy, is too intrusive. But having surgery, they're just as hesitant for that because of its invasive nature and because there's a lack of guarantee. So why are they coming to us? These patients are coming to us because they're hoping that we can provide an option that's less invasive and a bit more conservative. And this lines up well with our general philosophy of care when it comes to otolaryngology. Our philosophy of care is to exhaust all conservative measures where possible before considering surgical intervention. And you could see this clearly in the field of rhinology. If we take an example, we have a patient, John Smith. He is presenting with a history of non-allergic nasal congestion, nasal obstruction at night. On physical examination, he has a mild septal deviation, some inflamed turbinates. The conversation starts with lifestyle modification, elevating the head of the bed, humidifier in the bedroom, saline rinses. If symptoms persist, then we move on to active non-invasive treatments such as corticosteroid sprays, steroid-impregnated rinses. And then if symptoms still persist over time, both the physician and the patient feel more confident about starting a conversation about surgery. If we take the same situation in a sleep context, we have our patient, John Smith. He is presenting the history of snoring, fatigue. He's diagnosed with primary snoring, mild sleep apnea. He's not tolerating CPAP or the oral appliance. We do our physical exam and we see that there's no significant tonsillar hypertrophy. The remainder of the exam seems non-remarkable. So we start a conversation with lifestyle modification, weight loss, altering the sleep position with or without the help of a device, avoiding alcohol or sedatives. But then if that patient continues to have symptoms, either we tell the patient that we have nothing more to offer them, or we start talking about surgery. Now, sleep surgery has come a long way, especially with the introduction of sleep endoscopy, where we're able to be more selective with the patients that are being chosen for surgery. But there's still lots of challenges. With sleep endoscopy, we still need to develop a more standardized approach where we could improve patient selection and therefore improve the surgical outcomes that we're getting. And with surgery, the risk has to be acknowledged. So this is all within the setting of dealing with a patient with mild sleep apnea who may not want surgery to begin with. So it's beneficial to the patient and to us to be able to offer that patient more non-invasive options before moving on to the step of surgery. So what are the non-invasive options at this point? You may have patients that ask you about myofunctional therapy. And myofunctional therapy is a series of exercises that is focused on tongue function, position, nasal breathing, lip seal, is typically carried out by a myofunctional therapist. And there has been published benefit when it comes to treatment, effective treatment for patients with snoring or sleep apnea. But there are some challenges when we're looking at myofunctional therapy. Some of these challenges are this form of therapy, it's a broad concept at this stage. Various goals involved when it comes to myofunctional therapy. The goals may be to improve speech, swallowing for kids to improve oral growth, in addition to snoring or sleep apnea. So there is no standardized approach at this time when it comes to the type of exercises that should be given to a patient and the duration of time for which the patient should do these exercises for. So the effect is still unclear. It's also unclear within the severity of patients who have sleep apnea, mild, moderate, severe, which patients truly benefit from myofunctional therapy is not clear. The other challenge with myofunctional therapy is adherence. These patients do require training, practice, often under the guidance of a myofunctional therapist, and it can be challenging for patients to follow through with this therapy. So the treatment option I'm going to speak about today is neuromuscular electrical stimulation therapy. So what is the mechanism by which NMES works? To start answering that question, I think we should first acknowledge that there are several mechanisms of obstructive sleep apnea. The mechanism that we're most familiar with is anatomy. Perfect example, we have an otherwise healthy child with enlarged obstructive tonsils, adenoids, diagnosed with obstructive sleep apnea. Subsequently, their tonsils and adenoids are removed. And more often than not, the obstructive sleep apnea is resolved. However, when we have a scenario where we have a patient that has obstructive sleep apnea, we perform a physical exam and we're not seeing any significant anatomical findings, be it awake or even on sleep endoscopy, then we have to consider that there may be other mechanisms involved in that patient. And I will briefly touch on some of those mechanisms here today. So one mechanism is loop gain. So loop gain in the context of sleep apnea is pretty much an assessment or looking at the overall stability of a patient's respiratory or ventilatory system. It's looking at whether or determining whether a patient's ventilatory response to any breathing disturbance when they're sleeping, whether that response is appropriate or proportional. The other mechanism is lung volume. And lung volume is based on the fact that end expiratory lung volume is inversely correlated to the collapsibility of the upper airway. Another mechanism is arousal threshold. Arousal threshold is how easy is it for the patient to wake from sleep. Now, the mechanism of interest here in the context of NMES therapy is upper airway dilator muscle activity. What is the ability of the upper airway dilator muscle to maintain an open patent airway when the patient is sleeping? Now, there are 23 pairs of upper airway muscles. The genioglossus muscle is the largest upper airway dilator muscle, and it is a skeletal muscle, so it consists of different muscle fibers. Type 1, slow twitch muscle fibers, that's responsible for long-acting endurance activities. And you have type 2, fast twitch muscle fibers. These are more for fast-acting, powerful movements. Studies have shown that the genioglossus muscle is needed to maintain an open airway in a patient, and also the genioglossus muscle in of itself is sufficient to do so. So if we're looking at the genioglossus muscle, a question would be, what is the function of the genioglossus muscle and how may it differ in patients who have obstructive sleep apnea compared to those who don't? So a study was carried out to answer this question. And what they found was that patients who have obstructive sleep apnea, they actually have stronger genioglossus muscles compared to their healthy counterparts, but those muscles have a much lower endurance. So those muscles fatigue much more easily, making the patient more susceptible to having collapse into the upper airway. So the natural follow-up question here, again, looking at NMES, is does NMES induce any changes in strength or endurance of the genioglossus muscle? Now, to start answering this question, participants in a study were given a device called the eXciteOSA device. The eXciteOSA device is a neuromuscular electrical stimulator that is Bluetooth controlled, so it connects with a phone through the eXciteOSA app, so the patient can regulate their own stimulation intensities. If you look at the picture on the lower portion of this slide here, you're looking at the intraoral portion of the device. This is made of a silicone material, so it's very flexible. So there's a universal fit for this. And on the intraoral portion of the device, there are 4 contact points that deliver the stimulation. You can see 2 of these contact points here. So the authors of this study basically recruited 20 participants, 9 with primary snoring, 11 with mild obstructive sleep apnea, and they instructed them to use this eXciteOSA device. They instructed them to use it twice daily for 4 to 6 weeks. There were baseline measurements of strength and endurance, and then measurements post eXciteOSA therapy. And what they found was that when it comes to strength, there was no change in the genioglossus muscle activity with strength. And that was expected based on previous studies. But they did see a significant increase in the endurance of the genioglossus muscle. And what was interesting about this was that in patients who had this increased endurance, who had mild sleep apnea, there was a 57% reduction in their AHI over that 4 to 6 week period. So the question then is, why does eXciteOSA increase endurance? If we go back to the genioglossus muscle, again, it's a skeletal muscle, consists of 2 fibers, type 1, slow twitch, long-lasting endurance fibers, and then you have the type 2 fast-acting muscle fibers. eXciteOSA stimulates the genioglossus muscle at specific low frequencies ranging from 3 to 20 hertz. And it's been shown in other studies that neuromuscular electrical stimulation at similar low frequencies actually causes a transition from fast twitch fibers to slow twitch fibers. So the hypothesis here is that eXciteOSA is doing the same thing. It's promoting a gradual shift from fast to slow twitch endurance fibers. So multi-center clinical trials were then performed to look at the effect of eXciteOSA on snoring, daytime sleepiness, OSA severity. And these trials were carried out in multiple centers in the UK and in Spain. They recruited 115 participants. 50 of these participants had primary snoring. 65 of these participants had mild obstructive sleep apnea. They were instructed to use the eXciteOSA therapy once daily for 6 weeks. So when it comes to snoring, subjective and objective outcomes were assessed. And some of these outcomes are shown here. Subjectively, the participant's bed partner needed to report on their snoring intensity pre-eXciteOSA therapy and post-eXciteOSA therapy using visual analog scales. Objectively, the snoring was assessed looking at the percentage of time a participant spent snoring above a level of 40 decibels. Now, to put that into context, conversational speech is around 60 decibels. A lawnmower, which snoring can sometimes sound like, is approximately 90 decibels. And they recorded this pre-eXciteOSA therapy and post-eXciteOSA therapy. And what they found was that there were significant reductions seen in both subjective and objective outcomes. So a further analysis was then done looking at the effect of eXciteOSA specifically on the subset of patients who had mild sleep apnea. And they looked at the effect in terms of the changes in the Epworth Sleepiness Scale and reductions in OSA severity. On this slide, we can see that there was a significant reduction in the Epworth Sleepiness Scale in these participants with mild sleep apnea. The reduction here is approximately 3.4 points seen here. And when it comes to obstructive sleep apnea severity, they found that there was a 78% responder rate, or 78% response to eXciteOSA therapy. Now, response here is defined as any reduction in the apnea-hypopnea index. Of these 78 responders, the average reduction in AHI was found to be 52%. Now, in this study, there were no major adverse events that were reported. Approximately 15% of the participants reported on minor adverse events. The most common adverse event reported was pooling of saliva. Others seen here: tongue tingling, tooth sensitivity, metallic taste, gagging, tightness of the jaw. And these were found only during the period of time when the participant would actually use the eXciteOSA therapy, and it tended to reduce over time. So who are the candidates for eXciteOSA? Patients with primary snoring, mild obstructive sleep apnea, patients with a BMI less than 35, patients who are 18 years and older. And contraindications. Contraindications would be patients with confirmed or suspected pregnancy, patients who have a pacemaker or any implanted electrodes, patients with intraoral ulcers that can cause discomfort, any dental jewelry, and having an AHI greater than 50. So how is the eXciteOSA device used? There are two phases. During the first phase, patients are instructed to use the device once a day for 20 minutes every day for 6 weeks. At that point, they can then move on to the second phase, which is the maintenance phase. The recommendation here is to continue to use it twice per week. Now, when it comes to the stimulation intensity levels, this is all controlled on the patient's phone through the eXciteOSA app. And the stimulation intensities range from 1 to 15. Now, every patient's tolerance to stimulation is different. So basically, a patient should be counseled to start at a level that's tolerable to them and gradually progress over time. When it comes to adherence for any treatment, we're seeing more and more now that patient engagement is a key factor. And this is where the eXciteOSA app comes in. The eXciteOSA app serves to educate the patient about the therapy that they're actually performing, motivate the patient as they're going along, give them real-time feedback about how many days, how many sessions they've used, and also to give reminders if there's a day or two that's missed. So how well have patients been adhering to therapy? And adherence here is defined as the percentage of days completed during phase 1 of therapy. So this is a graph basically showing adherence from the time that eXciteOSA was introduced back in 2021. And it's showing that overall the average adherence is 81%. Now this is based on US data. So now we'll talk about my clinical experience with eXciteOSA thus far. So with my experience, given our provincial restrictions when it comes to the certain number of in-lab sleep studies that a patient can have, and the fact that home sleep studies are not covered, I have chosen to use other outcome metrics here to determine response for my patients. The outcome metrics that I use, one, a snoring scale, and the scale that I use is the scale of subjective snoring from Stanford. Okay, you can see a scale here starting at 0 being no snoring, 1 to 3 being mild, so it's not disturbing the bed partner during sleep. 4 to 6 means that it's high snoring, that is disturbing the bed partner. 7 to 9, very high, it's disturbing people in other rooms within the household. And at 10, it's intense. The bed partner has usually left the room at this point. Other outcome metrics that I look at are the Epworth Sleepiness Scale. I've also now started to encourage my patients to download the SnoreLab app. The SnoreLab app pretty much gives patients a real-time feedback in terms of how many times they were snoring per night. They have their own grading system of how intense the snoring was, and it gives you an objective numeric score. Lastly, overall subjective global assessment, speaking with the patient and finding out what was their experience like, and do they feel like they've received any benefit from the therapy. So I'll go through a few cases here. So here we have a case of a 43-year-old male, BMI 27.2. He presented to me with symptoms of loud, intermittent snoring that were quite disruptive for his bed partner. On physical examination, there were no obvious signs of obstruction. On awake examination, his tonsils were grade 1. His uvula was not enlarged. Palate was clearly visible. There was no lingual tonsil hypertrophy that I can see. There was no retrognathia. He had a sleep study done. He was diagnosed with mild sleep apnea, and he decided to start eXciteOSA therapy. So at baseline, snoring scale 7 to 9, pretty high snoring. His Epworth Sleepiness Scale was at 5, and his SnoreLab score before starting eXciteOSA treatment was 78. On follow-up, these are his numbers here. So his snoring scale went from 7 to 9 down to 1 to 3. So it was no longer disturbing his bed partner. His Epworth Sleepiness Scale went from 5 to 3. And his SnoreLab score went from 78 down to 30. In terms of his global assessment, things are great. There are no further complaints from his bed partner, and he feels like he has pretty much improved energy levels because of using the eXciteOSA therapy. So this is the second case here. We have a 56-year-old female, BMI of 30. Symptoms that she presented with was snoring, daytime fatigue, and she's had chronic snoring, but her concern was her fatigue. She basically required daily naps. She had very low energy levels, and she believes that this happened pretty much right after menopause. This was particularly concerning for her because previously she was a very active individual. On physical examination, again, there were no obvious signs of obstruction that I can see on awake examination. So she had a sleep study done. She was diagnosed with mild sleep apnea. Her snoring scale, she scored it as a 10. Epworth Sleepiness Scale, 9, and her SnoreLab score was 60. On follow-up for her, this was a patient who was extremely happy with her therapy. The snoring scale went down to 1 to 3. Epworth Sleepiness Scale went from 9 to 3, and her SnoreLab score went from 60 down to 28. In terms of global assessment, her energy levels improved significantly. She no longer required daily naps, and she plans to continue to use her eXciteOSA therapy. So far, I have approximately 34 or so patients who are on eXciteOSA therapy. I have received reports or spoken to 2 patients who have concerns or have complained about the pooling of saliva. So now what I do with all patients considering eXciteOSA therapy, if they are about to start eXciteOSA therapy, my recommendation is once they start using it, it is hands-free, but avoid looking down. Looking down means that you can have pooling of saliva that's drooling now into the device that can cause malfunction. I encourage them to have a head neutral position, looking at the computer, TV, or phone, but maintain that neutral head position. I also let them know that it's okay to take the device out, take the device out intermittently. If you feel like there's saliva that's pooling, take it out, swallow, and then put the device back in. In terms of the number of devices that have been returned so far, there have been 4 devices. These are the reasons that I have documented here. 1 was for pooling of saliva. 2, it was a patient with severe temporomandibular dysfunction. So she had a lot of jaw discomfort, and she was not able to tolerate using the device for 20 minutes. The 3rd patient, his snoring did reduce, but it was still disruptive for his bed partner, so he returned the device. And the last patient obtained the device, but then found out that he needed a pacemaker in the near future, so he returned it as well. Now, of the 34 patients, 24 of my patients have been on therapy for at least 42 days now, and the adherence rate is 87%. And I think that in addition to the engagement and support from the eXciteOSA side, there are certain factors that can help to really maintain a high adherence in these patients. One is education. At the very outset, explaining to patients why they would use this therapy, what is the mechanism underlying this therapy, explaining how the device works, explaining to them the potential side effects and how to address them should they occur. Also talking about stimulation intensity, right? No one wants discomfort when using a device or form of therapy. So I let patients know that they should start at a stimulation intensity level that is tolerable to them, but then to slowly test themselves to see if they can increase to a level that is tolerable. And overall, on average, I'd say for my patients, they start at a level of five or six, and by the time I see them 8 weeks later, they're at an intensity level of 11. The other factor here is checking in with patients. I do have my team that would check in with patients midway through therapy just to see if there are any struggles, any challenges, to provide support to that patient. And then they have a formal follow-up with me 8 to 12 weeks after starting therapy. The other factor that I think has boosted adherence a lot is the SnoreLab app. There's nothing more motivating than seeing an objective number, a score that is going down as you're using the therapy. So I have a lot of patients who have been quite motivated having the SnoreLab app to document their real-time objective feedback. So a question that I get is there a role for adjunct therapy with eXciteOSA? Can it be used with other therapies? And I think it is an interesting question at this point, because I do have one patient. She's a 46-year-old female. She has a BMI of 23.2, and she presented to me because she is using oral appliance therapy, but she has persistent snoring. On physical examination, again, there were no obvious signs of obstruction that I can see on awake examination. And although she was fully informed that patients, the indication for eXciteOSA is pretty much patients who have mild obstructive sleep apnea or snoring, she came to me with a diagnosis of moderate sleep apnea, which she had at baseline. That's why she chose oral appliance therapy. So although she knew that she didn't fit the criteria in terms of indication, she made a fully informed decision to pursue eXciteOSA therapy anyways, in conjunction with her oral appliance. So she started off with a snoring scale of 7 to 9, and this is with her oral appliance. And at that time, I was not telling patients about the SnoreLab at that point. So she did not download the app at that time, and she did not fill out the Epworth Sleepiness Scale questionnaire. But when I did see her in follow-up, she noted that her snoring had gone down to 3. And so she continues to use her oral appliance therapy in conjunction with eXciteOSA. So I think there's a lot of potential that's there, and time will tell as research in this area comes out. Another question I get is for eXciteOSA, when I'm trying to select patients, are there any anatomic findings that help me to select the right patient for this therapy? And I would say that typically for me, there are no anatomic findings at this point that I can say help me to select a patient, but that makes some sense in the sense that we're dealing with a mechanism of action here, potentially, where it's based on abnormally reduced dilator activity when a patient is asleep, something that I cannot see. What I would say is that I do use anatomic findings as relative contraindications for eXciteOSA therapy, and these are specific to my practice. My contraindications are if I see obvious signs of anatomic obstruction, so a patient who may have grade 3 tonsils, severe adenoid hypertrophy, if there's moderate to severe grade 3 plus lingual hypertrophy, and looking at the shape of the epiglottis, looking to see if they have obstructive nasal polyposis, any severe retrognathia. These are just some examples, but if I'm seeing a severe anatomic obstruction, then there is a discussion with that patient to let them know that I'm not sure if eXciteOSA therapy can overcome the obstructions that I'm seeing on their exam. The other situation where I would be hesitant to recommend eXciteOSA therapy are for my patients who on sleep endoscopy, I'm not seeing any evidence of tongue base collapse. So in summary, sleep apnea is a global issue. It is undertreated, it is underdiagnosed, and it's something that needs to be addressed. And we as physicians, we have to be careful not to dismiss patients who snore or who have mild sleep apnea, because their symptoms often do have quite a significant negative impact on their quality of life. It's also important to remember that there is no single modality of treatment that's suitable for everyone. And that makes sense given how many mechanisms there are underlying obstructive sleep apnea. So I think it's good for us to start thinking about these mechanisms when we have a patient that presents to us with obstructive sleep apnea. We're not seeing any significant anatomic findings of obstruction, to start thinking about what other mechanisms may be coming into play here. Within the context of eXciteOSA, we may have a patient who has abnormally reduced upper airway dilator muscle endurance activity while they're sleeping. So I think it is worth discussing eXciteOSA therapy with our patients, because it offers a patient another form of a non-invasive treatment that's safe and that's effective. So for patients who are interested in eXciteOSA, I would recommend guiding a patient to this website where they would be able to get more information and obtain the device as needed. Thank you.
Thank you, Dr. Morong. Can you hear me?
Yes.
Okay, great. 87% adherence, that's incredible. Wow.
I know. And I think my patient population seems to be very motivated at the outset once they understand why they're having the treatment, and once they feel like they are making an autonomous decision for themselves. There isn't a therapy that's being forced upon them. They have time to think about it, and they make this decision of their own accord. And that in itself keeps them motivated. Along with the SnoreLab app, I think that has a huge part to play in it as well.
Great. Yeah, no, this was a lot of really great information, and it's nice to hear from an otolaryngologist and really get your perspective on the different alternatives to CPAP, because we know adherence isn't as great with a CPAP. So it's exciting, no pun intended, to see those types of results and that type of adherence. So thank you so much for sharing. We do have quite a few questions, so I'm just going to go ahead and get started with that. So if you do a sleep endoscopy, who needs eXciteOSA?
So with sleep endoscopy, I cannot say that I would choose someone for sleep endoscopy, for eXciteOSA based on sleep endoscopy. At this point in time, because sleep endoscopy, one, is somewhat invasive. And again, I'm dealing with patients who have mild sleep apnea who do not want any type of invasive treatment. So a lot of these patients start eXciteOSA therapy first. And if that doesn't work, then we regroup and talk about sleep endoscopy. Having said that, the few patients that have had sleep endoscopy, one, it would be patients who, as I said, I would say are not good candidates because I see no tongue base collapse happening at all. Patients who may have partial tongue base collapse, then it would form a part of our non-invasive discussion when we're talking about treatments, talking about oral appliance therapy, eXciteOSA therapy as the non-invasive options, given that I am seeing some partial tongue base collapse.
Okay, great, thank you. When do you suggest eXciteOSA and when an oral appliance?
Good question. Now, there is no head-to-head trial at this point comparing eXciteOSA to oral appliance therapy. If you look at the literature in terms of snoring reduction, for example, oral appliance therapy, there's a wide range from 9% to 70%, 70% being that they're not looking at 40 dB thresholds, they're looking at high thresholds. And here we have with eXciteOSA at least a 41% reduction. So it really comes down to patient preference. So we discussed the pros and cons, right? With oral appliance therapy, patients who opt for oral appliance therapy are often my patients who are already wearing mouth guards for grinding, for bruxism. So they're comfortable with it. It's something that's familiar to them. So they gravitate towards getting a combination oral appliance device for their bruxism along with snoring or sleep apnea. My patients who would gravitate towards eXciteOSA are patients who would prefer not to wear any device at night. And also patients who are more attuned to fixing. They want to find the root cause and fix what's going on versus using a device that just stabilizes their symptoms. So they gravitate more to eXciteOSA because they have a sense that they feel that they are making improvements to their body, which they are, and they don't have to deal with the intrusiveness of a device. So it comes down to patient preference at the end of the day.
Great, thank you. Do patients need a prescription to get the device?
No, they do not here in Canada.
So in the US, it is prescription based, but yes, in Canada, it's not. Would you try eXciteOSA for moderate or severe sleep apnea?
At this point, I would not. I believe there are clinical trials underway looking at eXciteOSA therapy in patients with moderate sleep apnea. So I am eagerly awaiting those results. But at this point in time, no, I have strict indications for basically mild sleep apnea or snoring. But I do have patients, for example, as the one I presented, where they would like to use it in combination, right? And that's where it's a discussion. Again, the patient is making an informed choice. They know that it's not indicated for them, but they may pursue it on their own anyways.
Okay. And yes, you are right. There are ongoing trials for the moderate, so you can look out for that data soon. How long should the maintenance phase last, and would it be daily?
So for the maintenance phase, pretty much the maintenance phase, the recommendation is twice per week. I would say, looking at my patients, I encourage my patients to use it at least 3 to 4 times a week to maintain the endurance that they have achieved. I often see better results with patients who are either continuing, so they continue with their once daily because they've incorporated it into a lifestyle regimen that they have, or reducing it, but only to 3 to 4 times per week. And this is something at this point that would be indefinite until there are further long-term studies that may suggest otherwise.
Perfect, thank you. How do you clean the device?
Cleaning the device with water. So basically the intraoral portion, take it out, rinse with water, and there are very specific cleaning instructions, detailed cleaning instructions for patients in addition to maintenance of their device. But rinsing it with water, leaving it to dry. I would not attach it to the control unit while it's wet, right, to avoid any malfunction. So rinse it with water, leave it to dry.
Okay. Question regarding Inspire. Can a patient use Inspire with eXciteOSA?
So Inspire is not offered here in Canada, and Inspire is a hypoglossal nerve stimulator, right? And this is a device that it comprises of 3 components. So one component is an impulse generator that has to be surgically implanted. The second component is a sensing electrode or sensing lead to detect inspiration. And the third component is a stimulation lead that stimulates the protrusor branch of the hypoglossal nerve to allow for tongue protrusion. Because of that, it's an implanted electrode. So it is a contraindication at this point for patients who are interested in using it with eXciteOSA therapy.
Okay, can it be a replacement for Inspire?
No, I would say not, in the sense of, well, one, the hypoglossal nerve stimulator, and again, we do not have it here, but the hypoglossal nerve stimulator is a device or therapy that requires surgery for one. So you do have that surgical risk of complications of infection, the device malfunctioning. And as of now, from what I recall in the US, the indication for Inspire is for patients with moderate to severe sleep apnea who have failed CPAP therapy. So completely different indications compared to eXciteOSA therapy that's indicated for patients with mild sleep apnea or snoring.
All right. We've got quite a few questions coming through, so try to keep up with them all. How quickly can patients start to expect results from the therapy?
So, good question. And what I would say is that we always encourage patients to basically complete the full phase 1, full initiation phase. And usually patients, when I see them in follow-up, be it at the 8-week point, that's where patients would let me know that they have received benefit maybe over the past 2 weeks, but not prior to the 6-week point. They're still at stimulation levels of 5, 6. So I haven't had a patient who said 2 weeks after using it that they've had amazing results. At that 6-week mark, that's where I can see that their intensity levels have started to plateau, right? So they've gone from 5, they've progressed up to 11 or so, and they're plateauing, and that's where they're seeing their benefits so far from the patients that I've followed up with.
Okay. Is it recommended for patients with enlarged tonsils or adenoids?
So one, in the clinical trials, grade 3 tonsils were excluded. And I would agree with that because there's an obvious sign of anatomic obstruction that's there. So I would think it would be extremely challenging or difficult for the eXciteOSA therapy to overcome such a significant anatomic obstruction.
Thank you. And we're just getting some questions about prescription and needing one. So in Canada, it's not, but yes, in the US, it is a prescription-based product, just so everyone is aware. And then we've got some other questions that we're just answering in the chat, but I think for right now, that's, oh, another one would be in a physical exam. What are you looking for in a patient that may be appropriate for eXcite?
So on my physical examination, I'm primarily looking for significant anatomic signs of obstruction. And this is for me because in my practice, I do have sleep endoscopy. So I let patients know and that it is part of my assessment. The first part of my assessment is the awake exam. And that is to see if there's any significant, so grade 3 plus tonsils, looking at enlarged uvulus, lingual tonsil hypertrophy. And this is all to see if anatomy here is likely a mechanism for that patient underlying obstructive sleep apnea. A patient who may be amenable to eXciteOSA therapy, typically those would be my patients that do not have significant signs of anatomic obstruction on physical exam, which again, it makes sense to me because there's a totally different mechanism occurring there. They have abnormally reduced endurance when they're sleeping, and that's something that I cannot see on an examination.
Okay. Great, thank you. Are there indications for pediatrics or teenagers, let's say?
Right now, the indications for eXcites for age 18 and over.
All right, that covers most of the questions. If a question wasn't answered, we will be able to answer that separately via email. And yeah, we're excited. It seems we've gotten quite a few questions here. So I know you've had an engaging webinar, Dr. Morong. So thank you very much for sharing your experiences and your clinical cases. And yeah, I'll leave it to you if you have any last words.
No problem. I'm glad to help. It's a new therapy. It's new technologies. It is the basis of my practice because patients come to me seeking alternative options. And I'm happy to see that there is a lot more research going into looking at mechanisms of sleep apnea beyond just anatomic obstruction, because we can see that that's not enough. So I encourage my fellow colleagues to explore other mechanisms. This is a classic example here of patients who may not have had an anatomic obstruction, but they have lowered upper airway dilator tone. And now with this treatment, we're able to provide more tailored treatment, which is something that's great to see. And I hope that we see more technologies and therapies that are even more tailored that come out in the future.